Good evening, everybody. I welcome you all to the Pediatrician Pathshala, Module 3. So, it's a guiding light to excellence.
Yeah. So good evening all. We are delighted to welcome all the pediatricians to today's Pediatrician Pathshala Scientific Convention Module 3, Issue 1. Last year, we successfully completed Pediatrician Pathshala Module 2, where we explored 5 crucial aspects of the rational use of antibiotics in respiratory tract infections. Your participation and engagement made it remarkable milestone. And this year also, we are going to release Pediatrician Pathshala Module 2 book in upcoming Pedicon. This year, we are proud to launch our Pediatrician Pathshala Module 3 with our scientific coordinator, Dr. Pramod Jog, who does not require introduction. And it's our great honor to have you, Dr. Bhaskar Shenoy, as a speaker for our Issue 1. Today's session will cover exciting and clinically relevant topics that will be of great interest to every pediatrician who is present here now. We have hybrid CME at 3 different locations. One is at Bhopal, MP, where Dr. Ajit Meena is moderating the session. Second is at Gondia, Maharashtra, where Dr. Sunil Deshmukh is moderating the session. And the third one is at Gurgaon, Haryana, where Dr. Shashidhar is moderating the session. I now invite Dr. Vanmati, who is Associate Professor of Pediatrics at Savita Medical College, Chennai, and who is a medical officer at Microlabs. She will introduce today's eminent panelist, and she'll take the program ahead. Over to you, Dr. Vanmati.
Thank you, Sureka. So, it is my immense pleasure to welcome you all to the Pediatric Pathshala Module 2. So, in this module, we have a scientific CME series on smarter diagnosis, smarter antibiotics. We also have interactive question and answer platform, and there are also videos regarding experts' view to excel pediatric practice, and there are also updates on antibiotic resistance. So this is the pediatric website in which you can download the pediatric companion textbook and also the rational use of antibiotics textbook by clicking to the icons present there. And the various modules and the videos that are being completed will be uploaded there. You can watch them anytime. And this issue 1, it is regarding smart diagnosis, smarter antibiotics, and also pediatric antibiotic stewardship updates and best practices. So this issue 1, for this module 3 issue 1, the speaker for today will be Dr. Bhaskar Shenoy and the moderator will be Dr. Pramod Jog. So it is my pleasure to introduce Dr. Bhaskar Shenoy. So he is a MBBS MFR CPCH fellowship in pediatric infectious diseases, and he also has a diploma in infectious diseases, fellowship in applied nutrition, and he is now the head of Department of Pediatrics, Chief Division of Pediatric Infectious Diseases in Manipal Hospital, Bangalore. He is also the chairperson of PIDA 2025. He is a Vice Chair Education Committee WSPID, and he is a Managing Editor of Pediatric Infectious Diseases Journal. He is Editor-in-Chief of Karnataka Pediatric Journal, and is a coordinator for IAP ID Fellowship in Pediatric Infectious Diseases. He is a member of ACVIP 2017 and in 2022-23, and he is an adjunct professor of pediatrics at Manipal University, and he is a honorable IMA professor of pediatrics. And our moderator for today will be Dr. Pramod Jog. He is a senior pediatrician from Pune. He is a professor of pediatrics in DY Medical College, Pune, and he is a president of IAP 2016. He is a standing committee member, International Pediatric Association 2016-19. He is ex-vice president, Infectious Disease Chapter IAP, and he is a standing committee member of ASPID. I now hand over the session to Dr. Pramod Jog, sir.
Okay, so am I audible and visible? Okay,
Yes, sir. That's all.
thank you. Once I asked this question in a meeting, and I asked whether I'm audible and visible. They said you're audible, visible, and horrible. So of course, I said, I think don't worry. Anyway, it's on a lighter vein. I'm glad that we are having this particular program related to antimicrobial stewardship. Now, many of my colleagues, they don't know what is the meaning of the word stewardship. So steward is the person who is, standing at the entrance of a five-star hotel, in simple words. You see many times, tall person welcoming you at the entrance of a five-star hotel, and he will only allow people who are going to stay in the hotel. Okay. He will not allow others. Similarly, pediatricians and physicians, they are the stewards of antibiotics. What do you mean? They will use antibiotics only when necessary, and they will not use antibiotics when not necessary. So that is in single sentence. Okay. But people use antibiotics whether they are necessary or not necessary, and that's the problem, and that leads to antibiotic resistance. Antibiotic resistance, WHO has put forth as one of the 10 important health problems of this century, and there are many other health problems, but antibiotic resistance is one of them. And that's why it is necessary that our colleagues what is the right route, what is the right duration of individual antibiotics. Okay. Some of my colleagues have decided to use very few antibiotics in the practice so that they did not tax their brains for remember the dose and the route of all the antibiotics. Of course, Dr. Bhaskar will elaborate more on that. Okay. Many times, there are people who over prescribe. That means they will not prescribe only one, but they will prescribe two, three. That's all because of no confidence. People read the Nelson's textbook of pediatrics when they pass out their MD or DCH, and later on they do not attend the important all throughout the life, isn't it? So you have to go to this Pathshala regularly, and Microlabs has taken this important step of arranging this Pathshala, and our guru is Bhaskar today, and I might be called as the headmaster or
Father
the
of
principal of that. Okay, no
Father
problem.
of Pediatrician Pathshala.
Okay, okay. And then, of course, people use overtly broad spectrum antibiotics. When simple narrow spectrum antibiotics will be useful, they use broad spectrum antibiotics. Like, I know obstetricians, as soon as the cesarean is done, they will start the child on cefotaxime and micacin for no reason. Okay, so that's another problem. And then unnecessary combination therapy, as I said, even, in the obstetric nursing homes and so many others. And they will use wrong dose. As I said, they might use wrong route and for wrong duration. And many times, the antibiotics are unnecessarily continued for a long time. And that also creates problems. So there are many things. So it is necessary that people know what is the organism prevalent in that area, so that the local sensitivity pattern, if it is known, then they can choose the antibiotics properly. So right dose, right route, right duration, then academically updated decisions, training of the mind, whether this is bacterial or whether it is viral, and then also avoiding combinations, and sending the cultures at the proper time, and giving the medicines of high quality. Many times people choose the antibiotics from what you say, a market which is not a very very standard market. So the name of the medicine is same, but the quality is not good. And there have been studies, I remember one study from Africa where chloroquine was given for malaria, but children did not respond. It was proved malaria, but no response. Why? Because the chloroquine content itself was so low, because the medicine was not a standard medicine. So there are so many factors related to antibiotic stewardship, antibiotic resistance, and the chairperson of the Pediatric Infectious Disease Academy, Dr. Bhaskar Shenoy, is the best person to tell us about this. So, Dr. Bhaskar, kindly take over from this onward, and let us hear from you your views about antibiotic stewardship. And then at the end, we can have questions from our colleagues, and then I will sum up the entire proceedings. Thank you very much. Thank you.
Good evening. Thank you, sir, for that wonderful compilation. In fact, you have made my job easier by uh, summarizing all the things beforehand only, so people know what we are going to do. So thank you so much. Thank you, Microlabs, for making this happen. It's a very good initiative. In fact, they present today's topic. They have given smart diagnosis, smarter antibiotics, and smartest chairperson.
Thank you.
So that is one thing. And diagnostic pitfalls, rapid antigen tests and evidence-based antibiotic used. And also they have given pediatric antibiotic stewardship updates and best practices, which contains resistant trends, antibiotic stewardships, optimized duration of some common respiratory infection like community acquired pneumonia, AOM, sinusitis, etc. So it is quite a huge the topic that they have been given, but I will try to concise it and make it very short and brief and interesting. So can I share my?
Yes, sir.
Okay. So first of all, let me talk something about what is antibiotic stewardship, and then what is the current problems and what are the current scenario that is across the world and across the country. So it is a silent pandemic, and we have to address the crisis of AMR, especially in our country. So I'll be talking about the burden of the problem, then inappropriate use of antibiotics, rational use, how can we do, what are the programs that are available, and a recommendation for some common infections. So antimicrobial stewardship resistance is not only a problem in India, it is a global challenge. About 4.59 million people who died in 2019, they suffered from drug-resistant infections. Imagine the quite huge number. And directly AMR was responsible for 1.2 million of those deaths. And the worst part is that 1 in 5 of those, it occurred in under 5 children. And if you look at the graph here, the third most important reason for death, global burden of bacterial resistance, that is antimicrobial resistance, constitutes third among the deaths associated with IMR. And in India, if you look at little older statistics, 2019, wherein nearly 3 lakh deaths were attributed directly to AMR, and about 10 lakh deaths were associated with the AMR because they had some other problem, but AMR contributed to it. So what is said is that by 2050, Asia is predicted to experience around 4.7 million deaths directly by AMR. That is quite a huge number, and we have to be cautious. There are 5 pathogens which are responsible for majority of the mortalities. It's E. coli, Klebsiella pneumoniae, Staph aureus, Acinetobacter baumannii, and Mycobacterium tuberculosis. These are causing various infections, tuberculosis, abdominal infection, UTI, LRTI, etc., etc. So these 5 Pancha Pandavas are very dangerous in the sense they are the important cause of mortalities in India. And the other thing is that we have antibiotic, but they have developed resistance to antibiotics. For example, the E. coli, if you look at the most of the antibiotics like ceftriaxone, etc., has been become very it has become resistant. The resistance pattern is quite high. And most of the other commonly available antibiotics also have shown resistance in Indian setting. And ICMR report 2023, if you look at the susceptibility of antibiotics is coming down over the period of years. Now, a small example is that E. coli, wherein 2017 to 23, if you look at the susceptibility, which was about 56% in 2017, has come to 42%. And similarly, amikacin, imipenem, and meropenem, the susceptibility has come down. And similar is the case with others. Acinetobacter the resistance reported is about 88%, and susceptibility to minocycline is 72%. There was not much of change in Acinetobacter, but if you look at Klebsiella pneumonia, Pseudomonas aeruginosa, Staph aureus, all the available drugs have shown increased resistance. That means a decreased susceptibility. The burden of the AMR among Indian children in the community-acquired pathogen is quite huge. Now we have reports or cases of pneumococci resistant to penicillin, resistant to cefotaxime. MRSA, the number of drugs which is resistant to MRSA, I mean, not responding to MRSA is quite huge. And so is enteric fever, wherein it doesn't respond to fluoroquinolones already, and it is shown, started showing resistance even to ceftriaxone also. And so with Shigella, which has shown resistance to cotrimoxazole, ampicillin, and fluoroquinolone. And E. coli again, especially when you look at a E. coli UTI, the most of the drugs are resistant. Even some of them have started showing resistance to meropenem also. Look at the way we are going. So drivers for AMR in low or middle income countries like India, there are various reasons. One is the, as Dr. Jog has told in the initial thing, that the inappropriate indication for no indication. A child newborn born just because it's precious baby, they give antibiotics. And the quality is one of the other important thing. Then dosing is very important, and especially we have seen pediatricians are quite good in giving a proper dose. But when the child gets admitted in allied subjects, for example, pediatric surgery or neurosurgery or orthopedics, the dose has been horrible. And self-medication and over-the-counter dispensing of the antibiotics. And when you prescribe the antibiotic, the patient may not adhere to the proper duration, proper dose. Some people, just because diarrhea has started, they may reduce the dose of the antibiotic, which may not be very, which may itself can lead to antibiotic resistance. And we have the access to the drug. For self-medication, you go to a medical store and then they dispense the medicine and inappropriate indication. For example, last time the doctor had given one antibiotic for ear infection, probably amoxicillin or amoxiclav. And this time diarrhea occurred. And the mother thought that one antibiotic is the panacea of all cure, and she gave for diarrhea also one antibiotic, that is amoxiclav. Child's condition worsened, and with the severe dehydration they presented. And this has happened many times in our case. And dosing is also, which I've already told, the suboptimal dose, the duration, the timing, the dosage, route of administration, etc., are all causes of inappropriate use. And inappropriate choice of selection, that is again because you should be well versed with what is the bug and what is the drug. Which bug, which drug should be used. That is very important. And it is not that there is one drug which is Ramabana of all the illness. It's not like that. And choosing antibiotic itself is an art. And as Dr. Jog told, don't start with the high end. If the child's condition, clinical presentation, that determines, and your clinical suspicion of the probable organism, that determines the choice of antibiotic, not otherwise. And the quality is one of the important things. We has clearly told that the quality of the drug and the manufacturing is very important. Dispensing is a problem, and lack of adherence to the thing. So there are other things also like poor infection control. After COVID, at least we have little better in the infection control, but still it is lacking even in the hospitals. And animal husbandry, that is one of the important things wherein they use antibiotics for as a growth promoter or to prevent disease, something like cholesterol, etc. And that causes very much of antibiotic resistance. And limited access to clean water and sanitation. And most important is that there is no surveillance system to monitor the AMR in India. That again, we never know what is the exact problem and then how to deal with it. So what are the strategies to combat the AMR? So as Dr. Pramod told, the antibiotic stewardship, what is it? We never know, and we should know the definition. So antimicrobial stewardship is a coordinated initiative that educates and encourages the prescriber to choose the right antimicrobial agent, right dose, and right duration with the aim to enhance the patient outcome and reduce the antimicrobial resistance. This is the definition of antimicrobial stewardship. The goal is that we healthcare workers, whether it is a pediatrician or surgeon or whoever it is, they use the appropriate drug at an appropriate dose and for an appropriate duration, prevent overuse and misuse of drugs, and help in keeping the resistance at a minimum. And this is a cost-effective intervention to optimize the use of drugs and then improve the patient outcome and reduce the AMR. And also, it helps to reduce the healthcare associated hospital-acquired infection, what we used to call, is now called as a healthcare associated infections. And that also will be reduced. WHO has come with what is called as aware classification of the antibiotics, which is a useful tool for monitoring the antibiotic consumption, defining the targets, and monitoring the effect of stewardship policies that aim to optimize antibiotic use and curb antimicrobial resistance. So WHO has grouped the various antimicrobials into three: A, W, and R. The axis group that contains about 20, at least for 25 common infections drugs, and these are available at all times and affordable and with a good quality. That is the most important thing for these commonly available drugs. It should be affordable, it should be good quality, and there should not be any out of stock any time. It should be available all the time. The next is watch group, that is are recommended for specific conditions. This cannot be given as a routine for every infection. And most of the highest priority critically important antimicrobials are there, and it is for both human and veterinary use. The reserve drug is a last resort when all the antibiotics have failed. So this is how the pyramid goes, wherein access, watch, and reserve. That is reserve is a very small group. Now, having spoken about the antimicrobial resistance and then burden of the AMR and then consequences, reasons, etc., let us specifically, because the topic given is respiratory infections. So we know that respiratory infection causes significant healthcare burden across the globe, and most of the infections are trivial and self-limiting. There are some infections like severe pneumonia or necrotizing pneumonia. The mortality and morbidity is more. And that is respiratory infection is the commonest reason why the irrational antibiotics are given. Now, what is our current practice? The most common reason for antimicrobial use in children in the office practice, if you look, one is the upper respiratory infection, second is the pharyngotonsillitis, otitis media. And if you look at the type of infections, most of these do not need antibiotics. But in practice, most of them will get antibiotics. That is the irony, and that is responsible for the AMR. Now, antibiotic prescription should ideally comprise of the following phase. First, when you are writing the antibiotic, you should always ask yourself the perception of need. That means, is the antibiotic necessary here? If at all I make a decision to give antibiotic, what is the most appropriate antibiotic? And what is the dose, route, frequency, and duration? And can I monitor the efficacy of the drug, how the child is responding to the drug? So whenever you are giving the drug, you have to write, in the sense you have to think of what drug you are giving, what you are giving, how much you are giving, how long you are giving, and how often you are giving. These are the things that you should always ask yourself for when you are giving the medication. So, as I told, excessive and inappropriate antibiotic use may cause failure of treatment and antibiotic resistance. And this is a vicious circle which goes on. So, having said that, are we using antibiotic judiciously in our practice? Let us understand with the help of some of the cases how rationally how to do that. Now, the first case, 1-year-old with the 2-day history of fever, cough, rhinorrhea, red eyes, rhinorrhea, running nose, then mild throat congestion, and there are similar cases in the family. You can see the throat. Throat is mildly congested, child at rhinorrhea. So if you look at this case, this looks more like a viral infection because the rhinorrhea is there. There are many other members in the family are affected. Red eyes are there. These are all indicators. This doesn't need any complex test to prove that it is a viral. Just a clinical suspicion is enough. Most of the infections in the office practice, 70 to even 80%, I will tell, are viruses. The commonest viruses are rhino, influenza, RSV, adeno, etc., etc. And we don't need to investigate in such cases. They usually people do CBC, throat culture. Throat culture, though, big no. There are medications. If you look at, it is only the symptomatic. And there are many other conditions which mimic the viral, which mimics bacterial infection. One is a hand-foot-mouth disease. The clinical diagnosis is more than enough. And measles, EBV, adenovirus. And fifth disease, herpetic gingivitis, herpangina, etc. So you can see here the adenovirus, the conjunctiva, the conjunctiva is congested with the palpebral conjunctiva having the sandpaper-like appearance. And all that is seen white on the throat is not bacterial infection. It can even be in viral infection, something like EBV. And if you can see the herpangina, a small ulcer here, the pharyngeal erythema will be there, but it is not bacterial because moment they see pharyngeal erythema, people do start antibiotics, which is not right. Pharyngeal erythema can be there in viral also. So there are many bacteria which can cause, which can be strepto, then mycoplasma, then Neisseria gonorrhoeae in adolescents, etc. But isolation of pneumococcus and Hib from the throat are not always mean that they are pathogens. They can even be colonizers. So I just mentioned about the throat culture, which is a gold standard of diagnosing to rule out test than a rule-in test. So it is not recommended routinely. And positive, if the test is positive, it doesn't tell that it is an acute infection. It can be from a asymptomatic carriage also. So it should be sent only for clinically suspected streptococcal pharyngitis, not otherwise. Negative test has a very high negative predictive value. And there is no hurry to start antibiotics in a pharyngitis or a throat infection. People say that I am scared about a rheumatic fever occurring. So what is said is that you can delay up to 9 days to start the antibiotic. It doesn't decrease the ability to prevent rheumatic fever by starting very early. So management, as I told, is just a symptomatic and counseling. And sometimes some of the symptoms like cold and cough can take around 2 weeks also. Now, another child, 2 years, 4 years, with fever, overfeeding, and diminished activity. He complains of pain and difficulty in swallowing, mild cough, but there are no similar cases. I'm just trying to compare with the previous case. And this child has a patch on the tonsil, and you can see the numberings are done. There's a whitish patch on the tonsil. The tonsils are enlarged and swollen, and then some petechiae, uvula is swollen, and even the tongue is little reddish and browny. So, grayish furry tongue. So, in a bacterial infection, generally the uvula is swollen, the tonsils are red and swollen, the throat is congested severely, tongue is gray and furry, and throat congested, I have already told. So, is there any criteria to suspect a group A streptococcus from group A streptococcus pharyngitis? So we have to do what is called as a Centaur criteria. Centaur criteria is a easy method in a clinical. You can distinguish between a bacterial and a viral infection. So Centaur criteria, you have to look for tonsillar exudate, tender anterior cervical lymphadenopathy, fever, and absence of cough. There is one more McIsaac criteria which even takes into consideration age also. So 1 point is given for each criteria. The if the total points are more, it is more towards a bacterial infection. So if the patient has less than 3 points, the chances of gas pharyngitis is very less. If it is more than that, they may be really suffering from it. So if you compare these two cases, the first one was viral because it was an acute onset, red eyes, cough was present, and pharyngeal congestion, but no exudates, no cervical lymphadenopathy, age less than 3 years. So probably viral. But the second case, age more than 3 years, toxic child, throat pain, congestion, follicles on the tonsil, bacterial. So 90% of the times, if you do this differentiation, you can avoid antibiotics to a large extent. So investigations, it is mainly clinical. ASLO also people have done. And sometimes if you're in doubt, you can do what is called as a RADT, that is rapid antigen detection test, which is supposed to be more specific and sensitive, and it is cost effective also. Only problem is not easily available, but in the office practice, you can do the test to differentiate between a bacterial and viral, and when you have test. It's a simple test wherein you can, the test lines you can see. If it is positive, both lines will be red, and if it is negative, the test result will not be showing. So it is a, as I told, turnaround time is only 5 minutes. Within 5 minutes, you can tell whether it could be bacterial. And I think we should propagate this among pediatricians as a part of antibiotic stewardship. I think microlabs can take this step forward with sensitizing the pediatrician about the use of this particular test. So treatment, yes, antibiotics may be needed in this case. It reduces the spread of the infection to others. It reduces the suppurative complications. So when you are giving ideally penicillin, but penicillin is not available, amoxicillin, and in some cases amoxiclav, about 50 milligram per kg per twice a day you have to give. And those who are having penicillin allergy, you can have alternates like macrolides or cephalosporin. Sometimes non-type 1 only, you have to give cephalosporin. Okay. So the algorithm for this is once they come with those symptoms, you should examine the eye, ear, and if the child has conjunctivitis, hoarseness, cough, coryza, viral, 3 to 4 days you wait with the symptomatic, it responds. If the purulent patch is toxic, tender lymph nodes, even jugulo-digastric nodes are very important. It can be bacterial. So, and you can do a culture in some cases, but RADT is very important, which is positive. you can continue the antibiotics. So the summary of this case is that you can suspect group A beta streptococcus hematotic tonsillitis in a older child. It is a clinical diagnosis. RADT can be done. There is no hurry to start antibiotics. Even if you think that it is, if you are in doubt, you can wait for 4 to 5 days and then you can exclude other things and then start antibiotic. Penicillin, amoxicillin, amoxiclav are the most important drugs. And people are using cefixime, cefodoxime and whatnot. This is not going to help in upper respiratory infections especially. And the duration of the course, 10 days, is very important. The third case is 5 years old with the fever and headache. He had pharyngotonsillitis 10 days back, purulent nasal discharge, periorbital edema with the tenderness on maxillary sinus. So you know the diagnosis, sinusitis. And in the clinical settings, when do you suspect sinusitis? When the symptoms are persistent, 2 to 3 weeks, new onset of fever, and symptoms are severe. And most of the times, the common organisms are Streptococcus pneumoniae, NTHI, Moraxella, and Streptococcus pyogenes. So, symptomatically, here you may have to give antibiotic when you make a diagnosis. And still, the choice of antibiotic depends amoxicillin or co-amoxiclav. And 40 milligram per kg. And suppose you have started amoxicillin not responding within 72 hours, go back, switch over to co-amoxiclav. But the duration should be at least 2 weeks or 1 week beyond the symptom resolution, whichever is later. So the summary of sinusitis is that the worsening or persistent viral rhinitis, if it is continuing, then you have to think of this thing, sinusitis. It's a clinical diagnosis. People are taking X-ray. Sometimes opaque sinuses may be visible. And right duration and dose of amoxicillin, as I told, has to be continued. Next case is fever. 1 year, 3-month-old child with fever, rhinorrhea, and inconsolable crying. You know, child might be having acute otitis media, and you have to evaluate the tympanic membrane with a otoscope. You can see the bulging tympanic membrane with the redness, probably, it's a AOM. And once you make a diagnosis of AOM, you have to define the severity, whether it is severe or non-severe. Severe is one where the pain is non-responsive and toxic, child has fever. And in a non-severe, it is intermittent pain which responds to analgesics, but fever may be absent. Management, of course, saline nasal drops, some analgesics, paracetamol or ibuprofen, then antibiotic use. When it comes to antibiotic, again, if it is very less than 6 months, you have to go for intravenous, whether amoxicillin and ampigenta or ceftriaxone. But usually it is very uncommon in below 6 months unless there is some underlying problem. And the duration of treatment should be at least 10 days. But little older children, you can give 7 to 10 days. So 6 months to 2 years, moderate or severe, you can either give amoxicillin or amoxiclav at a 40 milligram per kg. And if a older child, you can wait if the child is not very sick, not toxic. So with the severe symptoms, treat with the antibiotics, follow up on 10th day. Without symptoms, if it is less than 2 years, bilateral, you should give antibiotics. And if it is unilateral, observe. And after 48, 72 hours, if it is worsening, then treat with the amoxiclav. More than 2 years, don't jump to start antibiotic. Follow up within 48 to 72 hours and treat with the antibiotic if the symptoms persist. So, antibiotic has to be given in some cases, not in all cases of AOM, antibiotics should be used judiciously. The other case is a 2-year-old with fever, cough, breathlessness, and signs of pneumonia is there. So once you make a diagnosis of pneumonia clinically, what you have to do? One is you confirm the pneumonia, that pneumonia is there. Second, you try to assess the severity, whether it is a mild pneumonia or a severe pneumonia. Then try to look at the etiology. Clinically, you can suspect the etiology. So etiology and severity is very important. This particular X-ray, you can see the shadow here. And etiology, how can you suspect? Usually, depending on the age of the child. See, Streptococcus pneumoniae is a common factor in 1 month to 5 years. But in a younger children, it's the viruses which can take upper end and chlamydia. In less than 5 years, in addition to streptococcus, RSV comes, and then even influenza. Sometimes in some cases, mycoplasma is another important thing, and then staph aureus in some cases. So, depending on the age of the child, you can suspect which organism. And more than 5 years, again, Streptococcus pneumoniae viruses are more common, mycoplasma, and in some cases, staph aureus, etc. It is very difficult to differentiate between viral and bacterial. And so the choice of antibiotic more than 2 months and for within 5 years, the domiciliary treatment for a non-severe pneumonia. I'm not talking about the severe pneumonia which is admitted in the hospital. For a non-severe pneumonia, the first line is amoxicillin or amoxiclava, about 40 milligram per kg per day. And next is staph, if you suspect amoxic or cloxacillin you have to give, or cefuroxime. And you have to red flag signs you have to inform the parents. Now the other question is, can multiplex PCR help in microbiological diagnosis? Let us see. So this is a 2-year child with the fever, cough of 6 days with fast breathing, and child was sick with the 88% saturation on NRM, and tachycardia, tachypnea, respiratory rate infection increased. And somebody did in a peripheral hospital nasopharyngeal swab which showed human metapneumovirus, and it was came to our hospital with the something like a ARDS picture, ventilated, and the tracheal aspirate was sent for multiplex PCR. And before the reports started on the ceftriaxone, vanco, etc. And the report came as again, this metapneumo virus was detected. But meantime, it also showed that Streptococcus pneumoniae also was there. So once we know that, we de-escalated it to ceftriaxone and stopped the other antibiotics. So de-escalation is also a very important component of antimicrobial stewardship. Respiratory panels, you have upper respiratory and lower respiratory panels. Upper respiratory, you can have throat swab, nasopharyngeal swab. Lower respiratory, you can have ball, then the sputum in a older child, or ET aspirate whenever you are in a ICU doing some procedures. But there are some limitations for that. They can detect only the targets for which the primers exist. Not like culture, wherein you put the culture and you find out some bug, even if it is rare. But here, whatever primers are preloaded, only those organisms are seen. And resistance gene which is detected may not belong to the organism detected. And as I told, it doesn't give comprehensive antimicrogram. And sometimes it is difficult to differentiate between a colonizer and a pathogen. For example, Streptococcus pneumoniae hippomorexella, which can be colonizer also, and sometimes it can be pathogenic also. And it can only detect the nucleic acid. So living or dead also it cannot detect. So these are the various respiratory panels that is available, and we have a rapid influenza detection test because sometimes some months back we had a huge pandemic, I mean epidemic of influenza. Of course, it has helped us to rule out certain things and diagnose. The other case is a 2 years male with fever, cough, and child had a brassy cough, which is quite playful in other times. And he had laryngitis also, and he was active, playful. It is a clear-cut case of acute viral croup. So management of mild croup is the look at the worsening. That is more important. Look at the worsening of the retractions, worsening of stridor. We have to monitor the child because they may recover or they may go, but there is no active treatment for that. Now this child worsened and crying and restless, and saturation is around 92 in room air, minimal retractions. Is a moderate cough. So moderate group, people have given antibiotic. Why I have given this case is that such cases you should try to differentiate between the group and other things, and then either you can give steroids in cases, or we may give nebulized adrenaline. But in a severe case, we may need uh, oxygen, but no role for antibiotics. That's what I wanted to stress. So, majority of upper respiratory infections are viral. Most of them are trivial. Some are serious. We should try to differentiate. So, the key messages are that irrational and overuse of antibiotics is a great concern. Start antibiotic only if it is indicated. Always use the first line drug unless the child is very sick, wherein you start with the high end drug and then try to de-escalate. And it is very important that we make use of cultures and other methods of diagnosis like microbiology, PCR, etc., so that we can be more rational in our diagnosis. Thank you very much for your patient listening.
Thank you, Bhaskar, for covering all the points related to the respiratory infections and also the antimicrobial stewardship. And there are only two questions from the audience. One of them is related to otitis media, and one of the delegates wants to know the importance of unilateral or bilateral otitis media in the selection of antibiotics. He is not very clear as to why unilaterality or bilaterality are taken as the basis for antibiotic therapy.
Yeah. So, what was the first question, sir?
No, same in otitis media. Uh, the protocol said that in unilateral or in bilateral, you know, we give antibiotics and sometimes
Okay.
we
Okay.
don't.
Okay. Okay. So, the most important thing is that if it is bilateral, it is more in favor of a bacterial infection compared to a viral infection. That is what is said in the literature. I don't know why it is like that, but that is the thing. That's why bilateral generally you give antibiotics. Unilateral, above 2 years, you wait. Below 2 years, even if it is unilateral, if it is severe, we do give. So it is more than the laterality, it is the severity, the toxicity, the fever, which is very important. So, and this is one of the things, but there is no clear-cut definition or the reason for why in bilateral is given and unilateral we wait. The explanation is that bilateral is more likely to be bacterial than in, say, unilateral.
Okay. And the second question is indications for amoxiclav as the first choice of antibiotic in pediatric practice. Which conditions?
Yeah. See, amoxiclav as a first. Yeah. See, when one is the local antimicrogram, I mean the antibiogram, it shows that there is amoxicillin resistance. The second thing is are recurrent infections, recurrent otitis media. The third thing is the otitis media with some underlying causes, underlying complications. Third thing is the patient has taken antibiotics in the previous 3 months. Suppose he has had, this is the second episode, and he has taken antibiotic just 2 months back or 1 month back with some amoxicillin. These are the cases wherein we directly go for amoxiclav. And you have started amoxicillin, and within 72 hours he doesn't respond. That is one more reason for starting amoxiclav.
Okay. And there is one question related to, again, amoxicillin, and which says benefits of oral amoxiclav versus cefpodoxime in otitis media.
See, amoxicillin is the, basically why we choose amoxicillin is the common organisms are Streptococcus, Moraxilla catarrhalis, and H. influenzae. And all are mainly sensitive to amoxicillin. Cefodoxime is not the first choice. That is because there are some cases of resistance to these antibiotics, and especially uh, in India, if you look at the chances of resistance to amoxicillin is very less. If you look at the Western literature, they say you have to give high dose, you have to give other antibiotics. But if you look at the Indian pattern, except for a few reported cases of the increasing penicillin MIC, but most of the cases have been found to be still they are sensitive to amoxicillin. And amoxicillin is lower on the thing. See, always we told you start with a simple drug or a narrow spectrum drug. So that fits into amoxicillin.
Right. I think most of the questions have been answered. So I think all the points related to antimicrobial resistance, antimicrobial stewardship, and special reference to respiratory tract infections, Dr. Bhaskar has covered in an excellent manner. He told us in the beginning that the organisms like pneumococci are becoming resistant. Staph aureus, in the form of MRSA, is presenting with resistance. Salmonella typhi is coming with drug-resistant Salmonella typhi, Shigella, and E. coli, particularly even in the urinary tract infections. So these are the important organisms which are posing a problem. And he has also explained the importance of the right dose, the right route, and the right duration. For example, in case of neonates, we always give medicines intravenously. So the route is very, very important. In children with neonatal meningitis, we never give oral antibiotics. And then the duration is for 3 weeks in case of neonates. So that's also important. So that is the importance of right dose, right route, and right duration. He has also told us about academically updated decisions. So he told us as to how to differentiate viral from bacterial. And the knowledge about microbiology is very important. He told us that pharyngotonsillitis in 70% cases is viral. Rhinitis, obviously, in almost all the cases is viral. Otitis media and sinusitis are bacterial, and that's why you can use medicines like amoxicillin or amoxiclav in these situations depending on the severity, recurrence, and so on and so forth. He has also explained about the management of children with pneumonia and also croup. The important point is that whenever you get a child with sneezing and wheezing, usually it is taken as viral and antibiotics are not required. Even change of voice many times is related to viral infections and antibiotics may not be required. The knowledge about the spectrum of the antibiotics is important. So, it is better to use narrow spectrum antibiotics to begin with and then go to the broad spectrum antibiotics. Many times in our discussions, we say that watery nose and watery diarrhea, they are not the indications for antibiotics. So that's also something we should remember. Then he has told us very important thing about the training of the mind. I always say that we have to remember three O's: the organ, organism, and the option. So if it is the lung, that is the organ. Organism is the pneumococcus, and the option is penicillin or ceftriaxone. So that particular knowledge comes out of training of the mind. So that's important. And he has also passingly mentioned about antibiotic audit. So in an institute, one must have the pediatrician along with the pharmacist and the microbiologist, and the team together can decide what is the drug of choice, antibiotic of choice for that particular ICU, NICU, PICU, or the hospital setting wherever antibiotic is to be given. And also, we had mentioned about the pricing is very important. Price in relation to quality. So what we call as value for money is also equally important. And he also told us that easy access to these antibiotics should be restricted. Otherwise, people are getting over-the-counter medicines. Also, he told about the importance of de-escalation. If you find that the organism is susceptible to a narrow spectrum antibiotic, then there is no need to continue the high spectrum antibiotic, which probably has been started. And he has also told us to be aware. Aware is the WHO classification, which says accessible antibiotics, then the ones which are available antibiotics which are in reserve. Okay, so access, watch, and reserve. So there is a classification of antibiotics given by WHO, and only the reserve antibiotics should be really reserved. Okay, those can be easily accessed or which can be used easily, that's fine, but then you have to be very, very clear about the access, watch, and reserve classification of antibiotics given by WHO. So it's very important. And taking a cue from his word that he used, Ramban. Ramban is, Ram was famous for, being Ekapatni, Ekavachani, and Ekabani, meaning thereby he was famous for, hitting the target with a single arrow. So, this reminds me of a story that, in a town, there was one person who was very famous for, hitting exactly in the center of a circle. And he was very proud that he is the only person in the town who can hit in the center of the circle. Now, once, he is traveling outside the town, and he finds many circles, with an arrow in the center. So he inquires as to who is the person in this town who has the art like me, because he was under the impression that he is the only person who can hit in the center of the circle. So people say, there is one person who is psychologically disturbed. He is a mad person. You go to him, he will tell you how he does it. So he goes to that mad person and asks him as to how he does that. So that mad person, so-called mad person, tells him, come here, sit down, I will tell you. So he tells him, my dear, it's very easy. First, I hit the arrow and then draw the circle around it. Okay. So the simple trick is told, and this is something which many of our colleagues, they try to do. They first give the antibiotics and then try to justify as to why they gave the antibiotics. This is something which should not be done. So you have to be very, very careful when you are doing this. During this journey, one may commit mistakes and may commit pitfalls, but it is important that you get up from the fall, get up, continue to walk, and from the side of pediatricians, myself and Dr. Bhaskar, I wish you continue to walk, and I wish you a very, very happy journey. With that, I hand over the proceedings to Dr. Surekha. And thank you, Dr. Bhaskar, once again for making this evening lively with your discussion related to antibiotic stewardship. Thank you.
Thank you, sir. As we conclude today's Pediatrician Pathshala Scientific Convention Module 3, Issue 1 on Pediatric Antibiotic Stewardship Updates and Best Practices, we extend our heartfelt gratitude to our esteemed speaker, Dr. Bhaskar Shenoy, for his insightful and impactful session. I must say, sir, in your busy schedule, you have created really insightful content for all the pediatricians who are present here on the same topic which we covered last year on the antibiotic stewardship. Today, we have seen totally different cases and updated content on antibiotic stewardship in real sense. All pediatricians can access the Module 2 topic on the antibiotic stewardship on our Pediatrician Pathshala platform, which has again very insightful content presented by Dr. Bhaskar Shenoy last year. So it was truly an honor to have you with us today, sir. It was Sri Ganeshaya Nama in real sense for Module 3. We also express our sincere appreciation to our moderator, scientific coordinator with a visionary behind our pediatrician Pathshala, the joyful Dr. Pramod Jog, who is father of our for skillfully guiding the session as always. A warm thank you to Dr. Vanmati and all the pediatricians who joined us today. Your valuable presence, enthusiasm, and commitment for advancing pediatric care is deeply appreciated. Before we close, a gentle reminder that you can download your participation certificate from the Pediatrician Pathshala platform with just one click. We look forward for seeing you again in our upcoming Module 3 session, Issue 2, under Smart Diagnosis, Smarter Antibiotics with another smarter speaker featuring another exciting topic. Thank you once again. Have a wonderful evening. Thank you, everyone.
Thank you. Thank you.
Thank you, sir.
Thank you.
Thank
Bye.
you, Dr. Bhaskar Shenoy. Thank you, Dr. Promoter.
Bye.